Okay, so let's get started. Today's session is part of the series of the Preventing Overdiagnosis conference that's being hosted by the University of Calgary. My name's Jenny Doust. I'm a general practitioner and a researcher in Brisbane, Australia. In Australia, we start our meetings by acknowledging the traditional owners of the lands on which we meet. So I'm talking to you from the lands of the Jagera and Turnbull people, and I invite you to reflect on the traditional owners of the land on which you are. And I want to pay my respects to the traditional owners and their contribution to our society and to our learnings, and pay our respects to the elders past and present. So today we've got two very interesting sessions on overdiagnosis and the history by two people who have been very involved in looking how the concept of overdiagnosis has been used over time. And then we have a panel session where people will be able to have questions and discussions with the panelists, and we've got two panelists that are very well known to most people, Barry Kramer and Steve Woloshin. What we'll do is each speaker will talk for about 20 minutes, and then when we open up the session to questions and answers, people will be able to use the question and answer function in Zoom to ask their questions. So start thinking of your questions as you're listening to the presentations, and then we'll be able to talk with both the speakers and the panelists at the end of the two sessions. And it'll be very helpful, I think, for people in the sessions to be thinking not just about what the history of overdiagnosis is, but then how that will shape us going forward, and what we can do to try and minimize the problems of overdiagnosis in the future. So we're just trying to make sure that our second speaker is on board, because there seems to have been a little bit of confusion with the time that was sent out. So we're just trying to make sure that he's actually here. So excuse us if we have to have some conversation between Geraldine and myself about what's happening there. But to get started, let me introduce our first speaker. So that's Scott Podolsky. He's Professor of Social Medicine and Director of the Center of History of Medicine at Massachusetts General Hospital in the USA, and is a primary care physician. So I have some affinity with that. With his background in both history and in medicine, he's well qualified to explain the conceptual origins of overdiagnosis and its social context. Okay, so over to you, Scott.
Thank you, Jenny. And I'll just start by saying I have no actual or potential conflicts of interest to declare in relation to this presentation. All right, so in April of 1924, at a conference of medical superintendents in Ottawa, James Douglas Adamson read a paper on the overdiagnosis of pulmonary tuberculosis. Harkening back to Hippocrates, he began with the aphorism, quote, "Phthisis is a disease which when incipient is hard to diagnose and easy to cure, but when far advanced is easy to diagnose and hard to cure," unquote. Stepping forward into the 20th century, he noted that such advances in treatment as a sanatorium could have all in turn increased the demand for early diagnosis, until now it is recognized as the sine qua non of adequate treatment. And yet, as he continued, such demand had an undesirable byproduct, which must be recognized and guarded against. That byproduct was overdiagnosis. And such overdiagnosis had real consequences. It was, quote, bad for the patient physically, financially, and psychically, bad for the physician mentally and morally, bad for the country economically, unquote. In France, for instance, during World War I, over 60,000 soldiers had been inappropriately removed from the front lines owing to such overdiagnosis. The chief motivation for such overdiagnosis, for seeing the enemy where he is not, was fear. As Adamson continued, quote, "The consequence to a physician who frequently misses pulmonary tuberculosis are most damaging. In the eyes of the profession, he is inefficient. In the eyes of the patient concerned, he is the one cause of all the vicissitudes of his subsequent illness." In contrast to this, physician who oversteps in his statements pays no penalty, and indeed his tendency to anticipate disease may indirectly contribute to his reputation as a therapeutist, unquote. It's a fascinating paper. It would be cited in 1925 in the Boston Medical and Surgical Journal as the New England Journal of Medicine, or NEJM, was then called, the first of over 180 eventual uses of the term in NEJM. Many of the themes that would characterize late 20th and early 20th century concerns regarding overdiagnosis will be manifested in Adamson's paper. The desire for early detection and hence treatment and cure, the fear driving such a movement, and of course, the potential for adverse consequences of such diagnoses. So this tension between diagnostic enthusiasm and skepticism dates back at least nearly a century, which is why I started my talk in this way. And yet there are instructive caveats regarding Adamson's paper and otherwise, which are important to lay out if we're going to approach overdiagnosis as a historically situated term signifying diagnoses that match existing established disease definitions, but that don't in fact help the patient and which in fact may cause harm. Stephen Woloshin and colleagues have written on what overdiagnosis is and isn't, and I'll largely be guided by their typology, drawing as well on Stacy Carter and Jenny Doust and their colleagues. So along these lines, what uses of the term overdiagnosis aren't we talking about today? We're not talking about overuse per se, though that's a related concern. We're not necessarily or just discussing the overtreatment that results from overdiagnosis. Critically, we're not discussing the term's usage as misdiagnosis, inappropriately labeling someone with another disease, another defined disease entity. This, in fact, was what was largely happening with TB in Adamson's paper. And in fact, the very next usage of the term overdiagnosis in NEJM by Paul Dudley White, a cardiologist in 1937, was used in the same way to refer to supposed heart attacks that were really gallbladder attacks or the like. Such common use of the term overdiagnosis to refer to misdiagnosis is related, in the case of the normal called the abnormal, to the notion of the false positive. From the early 20th century Wasserman test, concerns over false positive syphilis tests and their consequences onward. Again, it's an important category of usage of the term in the 20th century, perhaps the dominant one until the 1980s, but not what we're really talking about here or I imagine in the rest of the series. As a second broad category of usage we're not talking about today, there's been widespread application of the term overdiagnosis to refer to false, fake, or non-diagnoses, in which proposed disease categories themselves are challenged in their entirety, whether ascribable to quackery, seeming overenthusiasm regarding emergent disease entities, or apparent pharmaceuticalization. Again, in NEJM, we see this applied in 1974 to the seeming epidemic of overdiagnosed hypoglycemia in non-diabetic patients, moving the authors to title their paper, "Non-Hypoglycemia is an Epidemic Condition," unquote. We see it applied the following year in JAMA to ruptured cervical disc disease seen on film, buttressing the career of orthopedic surgeons seemingly fixing them. And of course, the term has been applied as a marker of skepticism with respect to apparent disease monitoring or pharmaceuticalization, whether applied to ADHD, low-T, SAD, or a host of other disease acronyms. But again, that's not what we're referring to today. Instead, the term, as used by Stephen and elsewhere by Barry, Kramer, relates to two related phenomena, both centered around the definition of established disease categories. The first use, especially as applied to cancer detection, entails the fuzziness within the boundary of a disease category like cancer, say breast or prostate cancer, in which the general category belies the heterogeneity within it, with some cancers destined to be aggressive and lethal, and others to be indolent. The detection of such indolent lesions is ultimately considered worse for the patient than they're ignoring, and hence in this framing constitutes overdiagnosis. The second usage applies to the fuzziness at the outer boundaries of a disease definition, especially a quantifiable one like hypertension or type 2 diabetes or osteoporosis, in which one is forced to evaluate the pros and cons of the expansion of categories like diabetes to prediabetes, hypertension to prehypertension, and so on, as well as the relationship between public health imperatives on the one hand and commercial or pharmaceutical imperatives on the other, in the ongoing construction of such definitions. So with these parameters in place, I'd like to situate the historical origins of overdiagnosis as used by Stephen and Barry, and as it emerged from cancer screening, especially, and to a lesser extent, at least usage-wise, with concerns about expanding disease definitions. These were, as noted, separate, but ultimately intersecting in linked concerns over the fuzziness of disease categories themselves and the consequences of such fuzziness. I'll focus on the US, though historian Ilana Lowry has already extended the history of the search for precancers beyond the US, and I'll at times draw on non-US sources. All right, so let's start with cancer detection and screening, which itself emerged from the late 19th and early 20th century rise of preventive medicine. As Barry's previously noted, in 1861, British physician Horace Dobell published his lectures on the germs and vestiges of disease and on the prevention of the invasion and fatality of disease by periodical examinations. This was echoed a few decades later in the US by physician and journal editor George Gould, who noted in his own advocacy for the periodic exam that, quote, all good medicine inevitably tends to become preventive medicine. He is the greatest discoverer who finds the pre-symptom. There are 100 known intimations and auras of oncoming disease, but there are 1,000 undiscovered ones, presumptions, advanced scouts, and forerunners to be learned when the slight and unconscious departures from normality are studied by examinations of the supposedly well. Unquote. In 1909, Harvard would form its own Department of Preventive Medicine and Hygiene. And by the 1910s, the combined influence of life insurance company exams, World War I screening exams, and TB control programs led to the increasing standardization of the prevention or screening medical exam, exemplified by the 1923 AMA report on periodic medical examinations of apparently healthy persons, in which they championed the detection of, quote, the early evidences of disorder before discomfort, inconvenience, interference with work, or anxiety has driven apparently healthy persons to seek medical advice for the treatment of established disease, unquote. This ethos would be taken up by a variety of organizations throughout the 1920s and 1930s to mixed effect. As applied to cancer, in 1907, Britain's Charles Child published the Control of a Scourge, or How Cancer is Curable, in which he posited, quote, cancer itself is not curable. It becomes incurable from the simple fact that its unfortunate victims harbor and nurse their cancers till it is too late. It is not the disease which is incurable, it is the delay that makes it so, unquote. By 1913, such a preventive ethos would be given publicity in the US through the advent of the American Society for the Control of Cancer, dramatically expanding by the 1930s through the formation of its Women's Field Army and the militarization of the seeming attack on cancer through early detection by physical exam. There were skeptical forerunners to Barry and Stephen even in the 1950s, as when Toronto's Neil McKinnon, contrasting the extent of such prevention and subsequent surgical efforts with stable breast cancer mortality rates, wondered aloud in 1955 whether many detected cancers may have been destined never to spread. As he bluntly stated, curing non-lethal lesions does not reduce mortality, unquote. That very same year, surgeon George Cryle Jr. published Cancer and Common Sense, bemoaning cancer phobia among patients and cancer exterminating perfectionism among surgeons, arguing that needless suffering and deaths were ensuing from the overaggressive treatment of cancers and their apparent precursors. However, just as skepticism was being expressed with respect to early detection by symptom or physical exam, a wave of new screening modalities was emerging, namely the Pap smear for cervical cancer in the 1940s and mammography in the 1950s, garnering increasing enthusiasm from the likes of the increasingly visible American Society for the Control of Cancer. Yet this enthusiasm would run into its own counterwave of skepticism, grounded in the linked rise of, number one, the randomized control trial, the RCT, as the increasingly visible arbiter of efficacy from the 1950s onward, including as deployed by the 1960s to evaluate such screening modalities as mammography. Two, the advent of Medicare and Medicaid in 1965, and the emerging push for the evaluation of federally funded measures. Three, the demonstration, especially at Dartmouth, of the variability in the deployment of particular procedures matched against less correlated variability and outcomes. Four, the rise of the Cochrane collaboration, what will come to be called evidence-based medicine. And five, a more critical depiction of the iatrogenic harms of medicine, as portrayed in scathing books like Ivan Ilyich's 1974 Medical Nemesis, but also in more measured and quite influential insider analyses like John Bylar's 1976 account of the potential radiation harms from mammography itself. Against this backdrop, and as illustrated by Bylar's article, the methodological dissection of the seemingly favorable mammography trials in particular led to concerns over particular forms of bias. These included lead time bias, which cancers detected earlier without influencing the ultimate time of death, giving the appearance of a longer survival period, length time bias, which slow-growing tumors are around longer and thus are more susceptible to being detected by screening programs, and eventually what would come to be known as an extreme form of lifetime bias, namely overdiagnosis. But overdiagnosis was clearly a term in flux. The 1980 American Cancer Society report on the cancer-related health checkup devoted a section to overdiagnosis, but acknowledging there is no sharp boundary between non-malignant and malignant cells, use it to refer to a lesion that is not cancer and would never become cancer, unquote. However, as the decade continued, usage of the term increasingly shifted to refer to what experts considered cancer, but non-progressing cancer, or cancer that would never otherwise have bothered the patient. Indeed, in 1979, Maurice Fox, again contrasting the discrepancy between breast cancer detection and mortality rates, had already asked clinicians to, quote, consider the possibility that there is an entity as yet not distinguishable morphologically from invasive cancer, but that will never or only rarely manifest itself biologically as cancer, unquote. By 1982 and 1983, we first see the term overdiagnosis explicitly used to refer to very slow-growing breast cancers in particular that would seemingly never become clinically significant. Again, Ilana Lowy has demonstrated a century's worth of attention to the significance and management of seeming precancers, as variously termed. But from the 1980s onward, such a focus was increasingly framed in terms of a particular cancer screening-related definition of overdiagnosis as an organizing term. While the U.S. Preventive Task Force did not use the term in its initial 1984 report on screening, in 1985, Richard Love used it to refer to the possible pseudocancers that could be detected through large prostate cancer screening by digital rectal exam, a harbinger of much debate to come, as we'll hear. That same year, epidemiologist Alan Morrison gave widespread credence to the notion in his monograph, Screening in Chronic Disease, through his preferred term, pseudodisease. Pseudodisease never really seems to have caught on in the way overdiagnosis would. By 1989, the term overdiagnosis as related to breast cancer was seemingly stabilized and defined by Peters et al. As, quote, a histologically established diagnosis of invasive or intraductal breast cancer that would never have developed into a clinically manifest tumor during the patient's normal life expectancy if no screening examination had been carried out. It was a definition that would soon be applied in the context of a host of other cancer screening programs. In fact, tracking the term in NEJF may be instructive. It was first applied in New England Journal of Medicine to breast cancer in 1992, to prostate cancer in 1994, and would be joined by focus articles on lung cancer in 2000 and thyroid cancer in 2014. It could be extended in this fashion beyond oncology, for instance, in 2015, to disease and evolution like appendicitis, or any usage where one posed whether a seemingly homogeneous disease category actually represented a heterogeneity of underlying pathologies, some warranting different or no treatment. The rise and fall of national childhood neuroblastoma screening programs, in which the enthusiasm for such programs was contested and curtailed by controlled trials revealing no benefit and significant overdiagnosis, represented perhaps the high water point to date of those warning of the perils of overdiagnosis, with the notion receiving its most popular counting in Welch, Schwartz, and Woloshin's 2011 book, Overdiagnosis, to the point where overdiagnosis had become an organizing notion for some, the foundation of a crusade to others. Its rise is easy to visually depict, whether through PubMed and its uses in the clinical literature, or on Google Ngram and its likely more popular uptake. And you can see how it really is well overtaken notions of pseudodiagnosis. The expanding approach to seemingly heterogeneous non-oncological disease categories would be paralleled by increasing attention to what Stephen has called the overdefinition aspect of overdiagnosis, concerning the expanding fuzzy boundaries at the edge of conditions like hypertension, diabetes, and osteoporosis. There are similarities between the overdetection and overdefinition classes of overdiagnosis. Both point to the adverse effects, psychological, financial, attendant to the labeling of those who would otherwise not benefit from the label. And both, of course, entail a number needed to treat -1 consideration of those treated and exposed to the risk of an intervention with no benefit. But there are differences as well. First, the definitional expansion of disease categories has generally entailed quantitative expansion. For instance, of hypertensives expanding from those with systolic blood pressures above 140 millimeters of mercury to those above 120 millimeters, rather than a qualitative one, though that can admittedly be a fuzzy distinction in its own right. Second, and echoing Stephen's reference to overselling, such definitional expansion has often taken place in relation to particular pharmaceuticals, which the drugs may in turn define or at least redefine the disease itself. This can be pernicious and bumps up against the fake disease category, where we use terms like disease monitoring, but it can be more nuanced. When there's a relatively safer, more effective, and or more convenient drug, the threshold to treat someone for something goes down, as I'll describe shortly. Third, such definitional expansion has taken place in the post-Framingham study era of the risk factor. It's been part of what Robert Aronowitz has called the converged experience of risk and disease. I'll spend less time on this overdefinition section for two reasons. First, quantitatively, the term overdiagnosis, while widely applied in this fashion, has still been used far less in this matter than the cancer detection sense. And you'll see, so this is all data that I quoted for the New England Journal of Medicine. It's in the 181 instances of usage I found over the summer. You'll see that up to 1992, it was generally used to refer to misdiagnosis, occasionally used in a definitional sense. But from 92 onward, it increasingly has been used to refer to cancer detection, really by 2-to-1 margin over misdiagnosis. And the definitional aspects, at least in medium, are far less. And within cancer, while it was initially primarily applied to breast cancer, prostate cancer has really overtaken it in the literature to this point. And even since I was working on this over the summer, there are more and more articles about this, and certainly you can have these slides. Second, as far as going back to the reasons why I won't be focusing quite as much on the definitional aspects, my colleague Jeremy Green, chair of the History of Medicine Department at Johns Hopkins, has written a fantastic book on this, which I strongly urge you to read. But I'll briefly summarize it for you. In short, as mentioned earlier, in the converging post-World War II rise of the risk factor and of the American pharmaceutical industry itself, previously overtly symptomatic diseases like malignant hypertension and diabetes were expanded to include silent disease. The headache and stroke-inducing severe hypertension of President FDR's era could only be treated with aggressive surgeries or toxic medications. But once thiazide drugs emerged in the late 50s, followed by 60 years of additional drug classes, the threshold to treat could be continually lowered all the way through to the sprint trials of the past decade. Likewise, once sulfonylurea pills were introduced in the 1950s, the threshold for calling someone diabetic, and from there pre-diabetic, could be lowered as well from the era of insulin alone. But there's been pushback for decades against such disease expansion, perhaps most famously embodied by the University Group Diabetes Program trial of the late 1960s and early 1970s, finding that treatment of patients with what were then considered milder forms of diabetes with oral tobutamide seemed to cause more harm than good. The term overdiagnosis seems to have been first applied in this definitional fashion with respect to diabetes in the Canadian Medical Association journal. Again, CMAJ has really been prominent in this history. In 1970, favorably, while it would first appear less favorably in NEJM in this form in 1984 to refer to overdiagnosed hypertension. It would actually underpin the first two chapters of Welch et al.'s 2011 book. Its usage has been parallel concerns about the commercial forces influencing such disease expansion and has achieved its own prominence in both academic and popular discourse. But this isn't to say that such invocations of overdiagnosis haven't produced their own form of pushback. At one level, There are, of course, those who believe in the utility of contested screening programs and or the benefits of particular expanded disease boundaries. At another level, there are those like Stephen and Jenny who've asked for and or provided clarification regarding what we actually mean when we use the term overdiagnosis, and others who seem to think the term itself has become too heterogeneously applied to be salvageable, asking for increased specificity when we describe the varied problems under their semantic and conceptual umbrella. Stepping back, however, the shared definition of an established diagnosis that doesn't help the patient at hand, and making patients, providers, and policymakers alike aware of the consequences of such a process does seem to perform a great deal of important work. And it speaks to the deep and enduring tension between enthusiasts and skeptics in medicine. In fact, concerns regarding overdiagnosis, whether related to screening or definitional aspects, parallel those in the history of therapeutics. Since at least the 1960s, distinctions have been rendered between therapeutic enthusiasts, those promoting novel pharmaceutical or surgical interventions, and the skeptics who have attempted to rein them in, with the randomized control trial often wielded by clinicians and regulatory bodies alike as a way to tame the therapeutic marketplace. As applied to screening and definitional forms of overdiagnosis, two primary measures have been promoted as potential cures. The first are fundamental mechanistic approaches to subspecifying seemingly heterogeneous disease categories like prostate or breast cancer into disease categories that should be treated and those that should be left alone. The second, again, is the empirical application of the RCT. And at the heart of this, the question of whether such RCTs, randomized controlled trials, should precede the widespread implementation of a screening program or disease expansion, of course, serves as a litmus test for any of us as an enthusiast or skeptic, as it does with therapeutic innovations and RCTs as well. There's a final caveat in this respect. My colleague, David Jones, describing the history of RCTs of therapeutics like coronary stents, points to Alice in Wonderland and the Red Queen running as fast as possible to stay in the same place. As soon as one modality is evaluated, often over a significant length of time and at great cost, the context and parameters of the intervention have changed. Non-coded cardiac stents have been superseded by drug-eluting stents and the like. The same Red Queen process with, for example, digital rectal exam complemented by PSA, in turn complemented by MRI, they apply, for example, to many evaluations of screening modalities as well. Our relative enthusiasm and skepticism will continue to be tested, but at the very least, we should know exactly what is at stake in the definition. Thank you.
So thank you, Scott. That was very interesting, and it's amazing how far back the term actually goes. It's quite extraordinary. Okay, so our next speaker is Ian Thompson. He's a specialist in urology oncology and practices in the Texas Urology Group. And as Scott mentioned, screening for prostate cancer has been one of the conditions which has really been at the sort of forefront of people's minds about overdiagnosis. And I think one of the ones where it's really most practicing clinicians, I think, understand the concept of overdiagnosis in prostate cancer. But it's also become obvious that there's other problems in neurology, such as renal cancer. Ian has been extensively involved with clinical trials in urology and the deliberations around prostate cancer screening. So he's going to talk about overdiagnosis of cancers in urology. Thank you.
Thank you, Jenny. Can you hear me okay? Beautiful. Okay, well, thank you and it's a real treat to be here with you. And Scott, enjoyed your talk, and been involved in GU cancers for 4 decades, and having witnessed this, all things are new again. I want to take you back and talk about some of the issues with regards to early overdiagnosis. I have a few disclaimers or a few conflicts of interest. I'm an employee of CHRISTUS Santa Rosa, which is a healthcare system. I work in some areas of prostate ablation. I have 2 U-Series grants from the NCI. I'm a consultant for clinical trials, and I am an emeritus professor for the University of Texas. Urologic cancers are very much a potential for overdiagnosis, and that's when you have diseases of high prevalence. As you can see here, prostate, bladder, kidney in males, and kidney and renal pelvis in females are fairly highly prevalent diseases. And when you have diseases of high prevalence for which there is not a one-to-one correlation with mortality, you run that risk. I want to take you back to a millennium ago. When I started as a resident, you could oftentimes see kidney cancers when the patients walked in. They were very large, or they bled, or they came in with pain. Oftentimes these masses were enormous, as you can see here on this right-sided kidney tumor. Big incisions, significant morbidity, long hospitalization, and oftentimes these patients presented with metastatic disease. We were oftentimes downhearted as we saw that these patients represented with chest metastases. And then I remember putting the first patients in an ambulance as an intern in the late 70s, early 80s, transporting them to our first CT scanner and having our eyes opened by the ability to see small renal masses. And we said, aha, an opportunity to control the disease and to treat it before it spreads. And indeed, you can see here on the right, these minimally invasive surgical procedures, laparoscopic or robotic. And we learned that you didn't have to take the whole kidney out. You could take out part of the kidney. So much better operations, higher cure rates. These patients oftentimes live for prolonged periods of time without metastases, less invasive surgery. We patted ourselves on the back, and indeed we found more tumors. Patients who presented with microscopic hematuria, and then the patients who had a CT scan in the emergency room for right upper quadrant pain, right lower quadrant pain, or just simply bloating, they would be found to have renal masses. But then we began to track this with mortality. One would expect as incidence rose that mortality would fall. In fact, very little impact whatsoever. And we learned that indeed it also depended on where you lived. The likelihood that you'd be found to have a renal mass. The more CT scanners there were in your neighborhood, the closer, the higher likelihood that you'd get a CT scan and found to have renal masses. And so we learned our lesson, and we said, we need to start offering active surveillance for these small renal masses, especially in elderly patients. I'll be the first to tell you, however, that just recently I saw an elderly patient working on a farm, 81 years old. Renal mass found a few years ago, increased in size. The family said, you know, we're worried that this may metastasize. We did an ablation procedure and he's got complications now. And you hit yourself upside the head, as we say here in South Texas, and you say, did you really help the patient? Which is the whole reason that we're actually here, as we all know. And in terms of prostate cancer, we have this issue tenfold greater. And when I talk to patients about high PSAs and early detection, I will tell them that some very simple statistics that grab their imagination. And that is, if you look at autopsy rates of prostate cancer, you could put a percent behind your age, and that's almost the likelihood that you have microscopic cancer in your prostate. With the median life expectancy in the United States approaching 80 years of age, that means that 3/4 of us at least will have some cancer in our prostate in our lifetime. With current early detection methods, what we're seeing is that 15 to 18% of people will be diagnosed. And yet by comparison, for example, a Caucasian male in the United States has about a 2% lifetime risk of dying from the disease. 80% have it, 2% will die from it. That means pretty high likelihood if you do early detection, and if you're good at that, you'll find a lot of cancers that don't need to be treated. And in terms of prostate, you can see this very simply. If you look at localized prostate cancer, there's a greater than 99% 5-year survival. In fact, there are fascinating papers on early prostate cancers that suggest that your longevity is longer if you have a low-grade prostate cancer than if you don't have prostate cancer at all, which is just an illustration on the potential for overdetection. And PSA, it's hard to say who discovered it, quote unquote. Hard to say exactly who popularized it, although there were several screening studies. And despite any evidence that early detection of prostate cancer with PSA reduced mortality from the disease, and with everyone knowing the potential risk of overdetection, we saw this enormous increase in the risk of prostate cancer with the proliferation of PSA testing in the United States. And that pretty much happened around the world in most developed countries. In the early 1990s, about 1992, Dr. Kramer was there for this experiment. There were a confluence of events that occurred. And this drug that you see here, finasteride, it recapitulates a genetic variant that if it happens in nature, men don't develop prostates, BPH, or prostate cancer. And it's used to treat male pattern hair loss, and it's also used to treat prostate enlargement. And with a modicum of evidence to suggest that it could prevent prostate cancer, we began this study. The men were randomized to finasteride or placebo and followed for 7 years. They all had a biopsy at the end of the trial. All of these men had to have a PSA of 3 or less when they entered the trial, a low-risk group of men when they entered. And when we analyzed the results at the end of the study, we were astonished that of the men who had biopsies, 15%, and this was only with 6 individual biopsy cores. Now we do 12, 18, 24 cores. 15% were found to have prostate cancer. And remember, a man's lifetime risk of dying from prostate cancer is 2 to 3%, so at least a 5-fold greater risk of overdetection. And it depended on the likelihood you can see here of the PSA. So if a man had a PSA between 2 and 3, 23% of these men were found to have prostate cancer. And if you apply these data to the general population, if you only biopsy men with PSAs above 4, out of a population of 10,000 men, you'll find 190 cancers. But if you just, pardon the dog in the background, this is the Zoom of the future, PSA of 4 or less, this population, you'd find 1,300 prostate cancers out of 10,000 men with only a sextant biopsy of the prostate. Then we saw the outcomes of 2 randomized trials. The European trial found a slight reduction in the risk of prostate cancer mortality in the men that were receiving PSA testing. The US trial found no difference in mortality whatsoever. But the point is that even if you tested PSA, you could still die from prostate cancer. And if you didn't, there was only a slight increase in the risk of dying from prostate cancer. This led to the proliferation of active surveillance because we realized, oh my goodness, these are a lot of low-grade prostate cancers that are being detected. And as you can see here, this is the Johns Hopkins series. There are now dozens of series of active surveillance where you simply monitor these men. And as you can see here, here's the likelihood of dying of any cause. Here's the likelihood of dying from prostate cancer. It's hard to see that this curve even leaves the x-axis over a prolonged period of time. But we could talk about overdetection and the nuances of it in prostate cancer for hours, but there are some fascinating phenomena that are associated with it. The way we grade prostate cancers to determine how aggressive they are, we use the Gleason's pattern scale. It was originally developed by Don Gleason such that if you had glands that closely recapitulated the glands of the prostate, it was a Gleason 1 all the way up to 5. Well, when I was a resident, we had Gleason pattern 1 and pattern 2. Those went away. They are now determined not to be prostate cancers. And Gleason 3, 4, and 5 are the only ones. These other ones are called non-cancers or BPH. And so when you have a biopsy core that looks like this, and you run into some pattern 3 and a little bit of pattern 4, that's called a Gleason 3+4. The predominant one is given first. The less common one, the second less common one, is given as the second. Well, we now know this is the original prostate cancer prevention trial distribution. These 2s and 3s and these Gleason 4s, they're not called Gleason 2, 3, and 4 cancers anymore. And effectively what's happened is that all of these, including these Gleason 5s, have now been moved up to a Gleason 6. So the Gleason 6 has been enriched with lower grade tumors. And so it's an interesting phenomenon that today an average pathologist will not call anything less than a Gleason 3+3 or a Gleason 6 tumor. And the challenge that we have is that there are some intra-individual variations in the way that the pathologist looks at the slide. And if the pathologist looks at the same slide over and over again, they may see a little pattern 4, which will then push the 6 to 7. It can't go down. And the best data that we have is that the kappa, or the reliability of Gleason scoring, is about 0.7. And just to show you the impact of this was a really remarkable paper by Peter Albertson. And what happened was that in the state of Connecticut, which was a SEER area for monitoring cancers and collecting all the data, there was a fairly substantial interest early on in watchful waiting for prostate cancers. And what they did was, in this Connecticut tumor registry, they looked at the men who had prostate cancer with original Gleason scores, and understanding that not only is there this truncation of it, you can't go below, but pathologists have been generally increasing the grade that they think that the tumors are. And so what they did was they looked at the original Gleason scores, which are the light grays, and then gave them a quote unquote contemporary score. Look what happens. All of these 6s were the original 2, 3, 4s, and 5s. They all populate there. But what has happened is that there's been a migration up. It's a grade inflation, if you will. And to show the impact of this, what Peter did was he looked and said, well, what do the survival scores look like? Well, here are the Gleasons before and the Gleasons after. You can see that the Gleason scores went down in 251 men, but they went up in 838. And to show that Will Rogers, meeting Garrison Keillor, and those of you who may not understand that, Will Rogers one time said that during the Dust Bowl days in the United States, when the Okies left Oklahoma and moved to California, the IQs in both states improved. And Garrison Keillor is a radio personality from years ago who said that all children in where he's from were good looking, and they were all intelligent, suggesting that they were that there are no lower scores, if you will. And just look what happened. Here was the original survival curves, as you see here. These were the original survival curves, and all of those survival curves improved, fundamentally because you enriched the lower risk populations into the subsequent ones. Unfortunately, it was pointed out just a few minutes ago This situation's getting worse because prostate biopsies in the 1980s, when I was at Memorial, my mentor did one core from the left side, one core from the right. In the late 80s, there were 3 biopsies from each side. In the early 2000s, 6 biopsies. So you're sampling more of the prostate, and these small tumors, there's a greater likelihood that you can find it. And the impact of the repeatedly examining biopsies for these patients, you can see that there is a substantial likelihood, if you put these patients on active surveillance, that the patients will be found to have a higher grade tumor and will go off active surveillance. We then realized that there was a completely unsampled part of the prostate. This is the rectal surface of the prostate. This is the urethra. This is the throw, if you will, of a biopsy needle. This entire area was not sampled. We now began doing MRIs, and you could see lesions in the prostate, and you would do the 12 cores posteriorly, and you'd add 3 to 5 cores for each suspicious region you see on the MRI. And with each biopsy, the risk of cancer increases. Interestingly, however, the MRI has a greater likelihood of showing lesions. And interestingly, it does, and this is, we'll see how this plays out over time. Lesions that are seen on MRI tend to be more aggressive than lesions that are found otherwise. And so we've seen this further explosion of prostate cancers. We know that many of them don't need to be treated. And as I pointed out, with active surveillance, for many of these low-grade cancers, the 20-year risk of dying from prostate cancer is 1% or less on surveillance. Now, the problem is, the fundamental issue with prostate cancer detection is that we treat them, oftentimes treat these prostate cancers. Now, if the cancer treatments were devoid of side effects, we could treat everyone with impunity. But unfortunately, side effects are common. There are urinary, sexual side effects. With radiation, there is a risk of developing secondary cancers. Just to show you a small insight into this, and this is a paper that's in development currently being evaluated, from the prostate cancer prevention trial and the select cancer prevention trial, which was a selenium and vitamin E prevention trial. What we did was we looked at men who were basically same age and they aged. We identified 23,000 plus controls, aging men, and compared them with their peers who'd been diagnosed with prostate cancer and either treated with surgery, radical prostatectomy, or radiation. And we measured this during the 7-year course of study, and for a total of almost 200,000 person years of follow-up, because we followed these individuals afterwards through the Medicare database. And we compared side effects and complications with patients having surgery, radiation, untreated cancer, as well as aging men. And just pointing out one of the possible side effects, which is erectile dysfunction, the black curve that you see here over the initial 8 years was the risk of developing erectile dysfunction in the men without prostate cancer. This was the risk of erectile dysfunction in men with radiation, the red curve, and the blue curve was the risk of erectile dysfunction in men undergoing radical prostatectomy. And you can see that fundamentally over half of the men, by only 7 years of follow-up, developed erectile dysfunction compared to somewhere around 15% or so in the men who were just normally aging. So the conclusions that you can reach with regards to overdetection and its impact is that there is a significant risk of detection of urologic cancers that will never pose the patient a risk. It's true for kidney cancer. It's true for prostate cancer. It may also be true for testis cancer, although much less common because it's an uncommon cancer. Bladder cancer appears to be significantly less likelihood to be the case. And even if these cancers that are of low risk are observed, It involves anxiety, invasive monitoring. Interestingly, active surveillance for prostate cancer is more expensive than having surgery, simply because you're having multiple biopsies of these individuals, multiple visits, and over half of the individuals who are being monitored will go on and be treated. And then there are the risks of the interventions themselves, some of which can involve other cancers. And obviously, these interventions carry significant risks. Solutions to this can include redefining low-risk cancers as another term. To a certain extent, we've done that by not calling Gleason pattern 1s and 2s cancers, but we still call Gleason 6s cancers. Laura Esserman and I, a number of years ago, coined the term idle lesions, indolent lesions of epithelial origin, and suggested that pathologists may not want to call them cancers. Unfortunately, that has not stuck. There is a reinvigoration of that effort currently by some of our colleagues. The other thing that can be done is to tune biomarkers or detection tests for higher risk cancers. And we've developed risk assessment tools so that you can evaluate a patient to preferentially detect high-grade cancers, because that's fundamentally the whole purpose of early detection of cancer, is to find a cancer that poses a man or a woman a risk of morbidity or mortality, and then to detect the cancer while it's still curable. That's the sweet spot. And unfortunately, what we've done is most of our tests are tuned to detect cancers as a whole, which then opens up the Pandora's box of overdetection. And obviously, the one thing that we oftentimes forget about is to focus on cancer prevention. Because if you can prevent cancers in the first place, you never have to worry about its prognosis and treatment. These are just a handful of some of the individuals that have made this possible. You can see Dr. Kramer down there at the bottom and Dr. Peter Greenwald. Lots of folks were involved in this effort, and I'd like to thank them all at this time. Thank you.
Okay, thank you, Ian. That was a great talk, really interesting. So now I'd like to open it up for the discussion with the speakers and also with the panelists. So just to introduce our panelists, I think a lot of people will already know them, but Barry Kramer from the National Cancer Institute and an expert on cancer prevention, and Steve Woloshin, who's Professor of Medicine at the Dartmouth Institute for Health Policy and Clinical Research. So we've actually got some questions happening in the question and answer section already, which is great. So what we'll do is I'll read them out to the speakers and the panelists and ask them to comment on it. So there's a couple of questions for Ian to begin with. So are any jurisdictions imposing an informed consent process prior to PSA screening as a means of addressing the problem?
Not to my knowledge in the US. We have suggested that as being a process that would be appropriate, if nothing more than a video. And we've suggested that that occur through healthcare systems. There are a few systems that have kind of dabbled with it, but it has not caught any traction. I will tell you that the American Urologic Association is re-looking at prostate cancer screening guidelines, and there may be a component of that that's going to be suggested into it. The other way that this could happen is it could be that the insurance carriers could mandate it. That's probably, if you want to have something with teeth, if the PSA test is not paid for, and either the patient or the physician has to pay for it, you might get some better informed consent.
Yes, yes, this is an ongoing issue, I think. And then another question from Eddie Lang. More CTs leads to fewer kidneys. Why isn't the media all over this?
I don't know. I mean, this is over detection. It's not unique to GU. I mean, it's present in every cancer, present in every disease, as Scott has pointed out. You could, a reporter could like specialize in this and could have a separate paper, separate Pulitzer Prize winner every weekend.
That's true.
You could do that research. I suppose that, and I'll just playing a historian, you could look at something like LexisNexis. I'm sure it's an easy narrative as a reporter to write about the importance of PSA testing or the importance of any kind of cancer screening. And, any sports organization is going to have rallying around this, and you could certainly write to advocate for prevention, harkening back in a Ben Franklin kind of way. But there are certainly probably lineages of reporters who are also writing about overdetection and its consequences as well. And I actually don't know the answer to Eddie Lang's question about what is the percentage in the literature on both in the popular media. It's a researchable question if you're really interested.
There's one other thing that I think every student of this should have in their hip pocket is the number needed to treat for all diseases. I mean, some of these things are astonishing. It's like aspirin to prevent the MI is like 100, 120 statins and so forth. And so it's not unique to cancer. It's everywhere.
Actually, I might just throw to Steve, because you've done a lot of work with media. Do you think the media is really over this issue enough, or is there something that they could be doing more of?
No, I certainly think there could be more. And that's actually something Barry started the Medicine and Media program about 15 years ago, which was a workshop for journalists to try to teach them how to do a better job reporting on medical research. And part of the curriculum focused on trying to sensitize the journalists to the issues about overdiagnosis. And sometimes you'd see a little spike in activity in the media, but then it would go away. So I don't know why it isn't more. It seems like the sort of thing that should have a lot of traction, but I can't explain it. No.
Okay, I'll go on to a question for Scott, and I'll come back to another question later. Okay, so a question for Scott. Was there a vested interest in the history of overdiagnosis? And also, this is for both speakers, what is the perspective of overdiagnostic trends after the COVID pandemic? Will it increase due to underuse during the pandemic, or will private institutions will lead to increased access due to financial interest? Okay, so to Scott first about the vested interests in the history of overdiagnosis.
Yeah, and historians are usually going to say it's complicated and it depends on context. Right, and there are different narratives that you could invoke. I mean, you could certainly take a somewhat cynical narrative of it's financially lucrative to diagnose more people and to treat more people. But it sounds, I was trying to illustrate that there's this longstanding preventive ethos, right? It's almost a commonsensical notion of an ounce of prevention is worth a pound of cure that certainly infused medicine at some level from the mid-19th century, and certainly around the turn of the 20th century, there was this whole advent of quote unquote preventive medicine. It seemed to make sense. So I don't think one had to be venal in looking to try and find prevention, but that doesn't mean that the person was right in doing so. There certainly have been financial considerations all along, whether that be, we could say urologists want to biopsy more prostates and take out more prostates. One could certainly make that claim, even if one thinks that those individual clinicians really think that they're doing good. There's certainly that's been applied to the pharmaceutical industry, and these are the very terms of pharmaceuticalization and disease monitoring, creating more patients. That's more about the definitional aspect than the detection aspect. And certainly this has all been evolving, of course, parallel to evolving legal system as well. And certainly fear of missing a diagnosis looms larger, and the consequences have often been larger than the consequence of overdiagnosing someone and treating someone who's probably ultimately grateful to the clinician for having taken out what may have been an indolent lesion. So I don't think there's a simple one. I mean, any given story has to be evaluated in sort of context and in a nuanced way, but I think there are multiple ways to interpret this history.
Yeah, it seems like there's multiple drivers, not just the financial ones.
Yep.
And does anyone want to jump in and say what they think the effect of the COVID pandemic might be on overdiagnosis?
Well, I can tell you that some institutional leaders in the field of cancer have expressed overt fear that the pandemic would lead to a reduction in screening, and they even have statistical models that projected there'd be about 10,000 lives lost over the next decade as a result of reduced screening and resulting treatment. However, as with all models, the real world had to be overly simplified. They had no idea how long the reduction would last, and so they projected that the reduction in screening would be at least 6 months or more. It turns out that emerging data suggests that there was an extremely rapid rebound in screening behavior even during the epidemic. And also the message didn't generate a whole lot of fear, because those 10,000 deaths over a decade were being compared to 600,000 deaths in 1 year from COVID. And so people felt they were justified in changing their priorities to try to avoid a disease that was causing 600,000 deaths as opposed to 10,000 over the next decade. But that said, the models are going to have to be recalculated because most models suffer because there's an assumption of linearity, and linearity has already been shown not to be occurring in screening behavior.
Yes. So question, this is going back to cancer and issues of overdiagnosis in different cancers. So this is from Inga Shabot. Should we call DCIS breast cancer, and should we call papillary thyroid cancer cancer? And what decision-making tools or shared decision-making tools would you recommend for those sorts of situations? So I think that's probably for you, Barry.
So that's a great question, and attempts have been made, not very successful. There was an NIH consensus conference on breast cancer screening and ductal carcinoma in situ. One of the recommendations was that the name ductal carcinoma in situ didn't match the better understanding of the biology of the lesion, and that the name should be updated, just like carcinoma in situ of the cervix. The name was changed to CIN, cervical intraepithelial neoplasia. I was at the conference and helped organize the conference. And so when the panel said maybe something like DIN, ductal intraepithelial neoplasia, should be used to replace DCIS, there was an uproar, and actually it came mainly from the medical community, and especially the surgeons and pathologists. Their feeling was that if you didn't call it a cancer, then it would confuse patients, and since the risk of death wasn't zero, although it's close to zero, then some lives would be lost simply because you didn't invoke enough fear in the woman. And so periodically, the sentiment arises again to change the name, but unfortunately, it has never caught on. Likewise, for papillary thyroid cancer, the same situation holds. These screen-detected small thyroid cancers are extremely indolent, and a terminology has been advanced for some of the small papillary thyroid cancers. But again, I haven't seen that really catch on. nor have I seen IDLE catch on, although I keep hoping that someday IDLE will take the field by storm.
So actually, I just want to raise something about this. So I'm not sure if it's relevant to the genitourinary cancers, but it's very relevant in breast cancer, which is where you get these kind of layers of diagnosis. So you get the initial diagnosis, and then you get these sort of sequences of testing where the patient has to kind of wait and hear whether they have, HER2 or all these different kind of tests that the cancer patients now have to go through. And that this kind of extends that whole anxiety about the waiting to hear what their treatment is, etc. Wondered if you had a comment on that.
Oh, it's actually it's not exactly the same for GU, but it's all that you have to do is we have a 2,000, about 2,300 patient active surveillance cohort. It's called the Prostate Active Surveillance Study. There's multiple ones of these, and if you look at the I think it's at 10 years, 12 years now, more than 50% of those patients have gone on to be treated. I think it's approaching 60% as you move out. Instead of being the HER2 and the series of layers of assessment, it's a prolonged multi-year approach to repetitive biopsies. And again, remember what I was talking about. In fact, one of our pathologists, Scott Lucia at the University of Colorado, is looking at this and kind of asking the question, if you give that same slide with that Gleason 3+3 that was seen on the first one, you give that same slide to a pathologist over and over and over and over and over again, just every 2 years with those surveillance biopsies. Doesn't take much for them to say, well, that might be a little area Gleason pattern 4 in there. Then it becomes a 3+4. The patient has been upgraded and the patient goes on and gets treated.
Yeah.
So we don't do the subtype analyses yet. Almost certainly we likely will. Now we're throwing MRs and more biopsies, and instead of doing 6 cores, we now do 20 cores, with each region of interest getting 3 to 5 biopsies. And so, yeah, kind of like that, but just a little different. But the whole thing leads to, once you have created, as Barry has pointed out, that cancer diagnosis, that has stuck. And then all that you're looking for is some increase to create more anxiety, and then the patient gets treated. And then you have the downstream. And with radiation, for example, we found a pretty substantial increased risk of bladder cancer and relatively modest follow-up in the patients that we now have with the long-term follow-up. And then all of a sudden you lose any benefit from the cancer treatment, especially in patients who were, to begin with, were pretty low risk.
Yeah, that's a direct physical harm, isn't it? There's a question from Mitchell. Yeah, yes.
I have a very related question to Ian, because he may be able to say whether the same thing is going on in the field of urology and prostate cancer. There were a number of risk predictors with multiple biomarkers for a given biopsy in breast cancer. And of course, the more biomarkers you have in the panel, the more likely it is that one of them will be abnormally high. And often surgeons will respond, and medical oncologists were responding to the worst biomarker. And so it did very little to decrease the aggressiveness of therapy. Ian, do you have any comments about?
Oh, yeah, we've got, the same companies make those same sets of markers. Generally, you send the slides off to those to get assessed. The challenge with it, I guess there's a sweet spot of those with the intermediate grades that you're not certain that there may be some features that suggest they ought to be treated, but the hazard that you run is in a general community of practitioners those patients, remember I said the Gleason 3+3 that's on surveillance, their 20-year risk of mortality is less than 1%. That if you then give that slide and run those assessments on it, your prior probability is only 1%, right? So all that you can do 99% of the time is create a false positive result. And that's the hazard that you have in a test there's not a proscribed way, what group of patients that you use it in.
Okay, so a question from Mitchell Rubin. What is the super sensitive PSA and is there any advantage to using it? And what is the role for prostate MRI in terms of preventing unnecessary biopsy?
Sophisticated question. So ultrasensitive PSA just measures to lower concentrations, and it's predominantly used for following patients after treatment, specifically after surgery, the very high-risk patients. And it actually is a pretty helpful thing in a high-risk patient that the PSA should be 0. Had a senior moment there. The other question was
the role for prostate MRI.
Oh, the MRI. Yeah, does it help?
Yeah.
If I were going to predict 10 years from now, I would not be at all surprised if we don't go from a PSA-based early detection to like breast, an imaging.
Yeah.
It's just amazing again, remember that you have this target that's full of little bitty cancers in most people, say over the age of 60 or 65. And if you do a bunch of biopsies, you can find prostate cancer in so many of those folks. And most of those cancers are inconsequential. And you can miss lesions that are consequential. And in fact, nowadays that we're seeing, if your MRI is normal and you do a biopsy, it's really unusual to have a high-grade cancer. Whereas MRI lesions, and we have, just like BI-RADS, we have PI-RADS, you can pretty much predict who are going to be the high risk. The problem with it is the PSA costs $7 and the MRI costs, I don't know, a lot. That's the problem with this. And the thing we oftentimes forget is in the United States, we spend like twice the percent of GDP than UK and Canada, and we have worse outcomes. And now if we're going to throw more to the MRIs, we'll spend 3 times our GDP and have worse outcomes. So that's the problem.
Yes. So a question from Bonnie Spanier. So I'll read out because the first part's really a comment, which is about M. Schomburg's 2011 data analysis for women with DCIS or stage 1 breast cancer over age 67 found an increase in longevity compared to similar women without breast cancer. So that she had improved survival. The difference between low-grade DCIS and high-grade DCIS, has anyone suggested a different name for these two very different looking DCIS categories? And I guess this goes back to Laura Esserman's work, doesn't it? That she was trying to encourage people to call things that aren't really going to progress to be called idle cancers. So yes, I guess that's a problem generally, that we have these things that as soon as it has the label of cancer, it's very difficult to tell people that it's not really a cancer, or it's only just a little bit of a cancer, isn't it?
And there's an interesting anecdote that we have high-grade prostatic intraepithelial neoplasia, high-grade PIN. That gets patients, they freak out over there because they look up neoplasia and in the dictionary, the synonym is cancer. They don't care that it's not cancer. They say neoplasia. And where that originally came from was David Bostwick and Michael I'm blanking, they identified what they thought was probably pre-malignant. And they found if you rebiopsied those men, you'd find cancer.
Yes.
What they didn't do was biopsy the guys that didn't have cancer in the first biopsy. And then it's this sticky fact, it's stuck and it's still there. And there's a pretty compelling evidence that if you have high-grade PIN, it does not increase the likelihood that you have concurrent cancer or that you will develop cancer.
Yes, yes, and that whole concept that cancers can actually go away again is quite hard for people to realize, isn't it? From Lance Bassick, I'd be interested to hear the panel comment on any potential for the emergence of personalized medicine through genetic testing to perhaps exacerbate the problem of overdiagnosis. Will this find its place in the medical history of overdiagnosis one day? And are screening programs for GU cancers a cautionary tale for these emerging medical technologies? I might throw that to Steve first, actually.
Sorry, actually, is there if I deflect it to Barry? Because just before
Yes.
this call, we were having this fascinating discussion, and Barry was talking about the liquid biopsies and such.
Yes, actually, Barry's an expert in this too. So, Barry?
Yeah, so I'm not sure if the thrust of the question is for the so-called liquid biopsies, where DNA fragments are measured in blood in the general population, which may well be a poster child in the future for overdiagnosis, because there you are looking for multiple cancers at the very same time. And there are two problems there. One is that you can identify fragments that are found in cancers, even in some normal people. The other is the specificity, so that would have to be worked out. Methylated DNA appears to be a little bit better, but clearly there's a potential for overdiagnosis. There's a potential for a net benefit. We don't know that. I think we're in the embryonic stages of blood testing for cancer. And it would, in my opinion, require a large-scale comparative trial to look at the balance of benefits and harms to such blood testing. And also, I think multiple companies may come up with their own unique patented test. And so what might be required is a bake-off to see who's got the best test to be put into the randomized trial. Now, if the thrust of the question is identifying people with familial syndromes, I think that's a little bit different. That's a very small proportion of the population, 5% of the population. And so at best, you are aiming to benefit a relatively small proportion, but there, the test performance is likely to be better. There'd probably be a little bit lower rate of overdiagnosis using the same test in a very small subset at extraordinary risk for cancer. So that may be one way to take a commonly used test and decrease the overall rate of overdiagnosis if you apply it only to the very high-risk people.
Barry, could I ask about if you take a test that you've developed the performance characteristics in the general population and then apply it in one of these high-risk populations, what assurance do we have that we'll find the cancer, not just find it, but find it sufficiently early so that we can have an impact on morbidity and mortality? The reason I ask is that when we looked at, in the prevention trial, we looked at the deaths from prostate cancer. We found that half of the deaths occurred with men who had their biopsies with normal PSAs. So I just want, the concern that I have is if we develop the tests in in the general population and apply them to the high risk, where you could have the phenotype could be different, or its metastatic potential could be different. Just curious what your thoughts are.
That's a great question. It doesn't have a great answer to it. I will say that it may well be that certain genetic syndromes predispose you to rapid progression, rapid metastasis, and therefore the same screening test may perform more poorly and detect the cancer only after it becomes incurable. On the other hand, it may be that the same tests would perform better. The way around it, of course, is to do a randomized trial. And I can't imagine doing a randomized trial in the tiny subset of people. So we're unfortunately left with retrospective analyses of a larger screening trial, looking at who might have been genetically predisposed. And we also may have to look at intermediate endpoints that fall short of mortality and take our best guess in that population that the test is as good as or better as it is in the general population. But I just think I'm a believer in randomized controlled trials, and that's one area where I think a randomized controlled trial is not going to be feasible or practical. Does that answer your question?
Thanks.
Yeah, it's a very complicated issue. I think we're all struggling with these issues in all the different jurisdictions around the world are struggling to work out how we evaluate these tests. Steve, I wanted to get you to talk about the news about the mesh heading for overdiagnosis.
Sure. I guess it's appropriate because we're talking about the history of overdiagnosis, and we're making history right now. What happened was, back at the first Preventing Overdiagnosis conference, Lisa and I put up a slide. We saw a slide like it today, where we just tried to show how common the term overdiagnosis was in the medical literature and in the media. And doing the searching was really a pain in the neck because there was no mesh term, and we were doing like full text searches, but we knew there were things that were about overdiagnosis. There were other things that weren't about, it was neither sensitive nor specific, and it was very, very annoying. And so we just kind of played around with the idea of trying to, figure out there must be a way to get a mesh term for it. And during COVID, having nothing to do, I decided to take it on as a project. So I called the National Library of Medicine and got in touch with the people who run PubMed. And I found out, and this is good for everyone to know, that you can nominate terms to be added to the index. And it's actually pretty easy. And you submit the term and a short explanation of why you think would be a good idea, why it would contribute to the world. And I spoke to a couple of people, and I had this big argument prepared, but the decision maker person, he cut me off right away, and he said, "No, it's a great idea. We'll do it." And that was the whole thing. And so then the question is how to write the definition. And we know many people have struggled with how to define overdiagnosis. So Barry, Kramer, and I, we tried to build on what we knew and what we had seen from other people's attempts. And we came up with a term that tried to include both of the kinds of sort of strands of overdiagnosis that we heard about earlier, both the overdiagnosis in the realm of cancer and screening, but also in the realm of disease definition expansion. And so we wrote a definition. There was a fair amount of back and forth because the PubMed has these people whose job it is to sort of weed through these the definitions. And eventually we got something that they found acceptable, and it's going to be announced next month. And but I can read it to you if you want, if you'd like. Now I know everyone, I guarantee no one's going to be happy So if you're not happy, you can blame Barry. But
Fair enough.
Here it is. And I'm not 100%. They told me that this is the final version, but it hasn't been published yet. So it may change. But this is the term. It's the labeling of a person with a disease or abnormal condition that would not have caused the person harm if left undiscovered, creating new diagnoses by medicalizing ordinary life experiences, or expanding existing diagnoses by lowering thresholds or widening criteria without evidence of improved outcomes. Individuals derive no clinical benefit from overdiagnosis, although they may experience physical, psychological, or financial harm. So that's the term. It's tried to cover all the bases. And there also, the PubMed's included pseudodisease as an official synonym as well.
Wow, it's great work. Great work. So I guess the challenge will be for the people doing the coding where authors of articles talk about overdiagnosis where they actually are meaning misdiagnosis. Yeah. That's going to be a challenge. But yeah,
that will be a challenge. But again, there are people, they have people who are trained to do that, that they train to do this. So hopefully, we'll see. That'll be an interesting research project.
It will make doing reviews about overdiagnosis a lot easier. So I apologize. There's one last question in the chat. We'll ask it, but it'll have to be very brief, the answer. So can anyone comment on the role of family history in screening decisions? For example, people with a first-degree relative with prostate cancer. So Ian?
So if you're interested in seeing how it works, we have a tool. It's called the Prostate Cancer Prevention Trial Risk Calculator, PCPT Risk Calculator. If you put that in Google and you click on the top hit, it will take you there. And it allows you to enter. So we have the advantage of having to our knowledge, the only set of data in whom men who all had biopsies regardless of their PSA. And we have some really remarkable data on the biases that are created for detection based on biomarkers. But it turns out that family history independently, everything being the same, family history increases the risk of first-degree relative. So that's a father, brother, or son with prostate cancer, and independently increases the risk of prostate cancer and the risk of high-grade disease. Some things have an independent, and interestingly, age is probably the strongest predictor, both of cancer and of high-grade disease. And it creates this very strange conundrum that the older you are, the greater the likelihood of high-grade cancer. So it leads to the strange situation where we think that we benefit people that are younger. So we drive the biopsies younger and younger to try to find people who have a long life expectancy, a long period of time at risk. But we generally, in so doing, we drive the detection of low-grade disease. And the converse is also true. It's almost an ageist bias that we ignore high-risk cancers in older men. And if you believe that a cancer-related death is just as bad in an elderly person as it is in a young person, it creates this very strange situation where you're over-treating the young ones and you're under-treating the old ones and say it's okay to die because you're old. No. All sorts of strange things come out of this. But yes, family history plays a role.
That's a very helpful thing to know. I've written that down because I'll go and look it up now. Okay, so I want to thank both our speakers and both our panelists. That was a very informative session, and it's great to have some good news to share about the mesh heading. Just a reminder that the next session in this series happens on the 23rd of September, or if you happen to live in Australia, it's the 24th of September. I'm sure everybody is missing the fact that we can't meet in person at the moment, but it's great that we can still have these meetings, and hopefully we'll get to meet in person soon. So thank you. Thank you. Big applause.
Thank you, Jenny. That was marvelous. Thank you, Ian. Thank you, Scott.
Yes, thank you. Wonderful.
Great to be with you all.
Our pleasure.